Hey everybody, my name's Nick Willis. Today I'm going to be doing my journal article on adding mobilization with movement to exercise and advice hastens the improvement in range, pain, and function after non-operative cast immobilization for distal radius fracture, a multi-center randomized trial. I know that's a mouthful. We're going to break it down. So basically, whenever you have a distal radius fracture, you're going to get these set of exercises and advice from a doctor that may or may not help it heal properly. So in this study, we're going to add mobilization with movement to those exercises and that advice. And later in the article, we're going to learn what that is exactly. A little background information on this article. It was published by the Journal of Physiotherapy in April of 2020. It has a great impact factor of a 5.6. Its authors are Susan A. Reed from Sydney, Australia, Joseph M. Anderson from Denmark, and then we have Bill Vicenzino from Brisbane, Australia. This trial is supported by a grant from the Mulligan Concept Teachers Association. Jump into the introduction. So distal radius fractures are the leading fractures in the world right now. They're the most treated by emergency departments, accounting for about 20% of all fractures. There's a predicted increase, according to this article, there's a predicted increase in the annual number of distal radius fractures in Australia, people aged 35 years or older. And the bad thing about these fractures is there's no evidence-based rehabilitation intervention. So basically, like I said earlier, there's these set of exercises and there's set of advice that a doctor can give you for a distal radius fracture, but it has not been clinically trialed or it has not been tested to see if it actually works or not. So in this article, we're gonna ask. The aim of the study was to determine the effect of adding wrist extension and forearm supination to exercises and advice when treating impairments after immobilization for a distal radius fracture. So we're going to add wrist extension and forearm supination to the common exercises they give you for a distal radius fracture. Our question and a hypothesis for this article, for this study. Our question is, does adding mobilization with movement, abbreviated MWM, to usual care, i.e. exercises plus advice, improve outcomes after immobilization for a distal radius fracture? So whenever you have a distal radius fracture, oftentimes you will not have it surgically repaired. You're going to be set in a cast for about 6 weeks, and then after that you're going to go through a little PT and like I said, like just a select few exercises. And so for this one, we're asking, does mobilization and movement, abbreviated MWM, help the healing process of a distal radius fracture? And our hypothesis for this is the addition of MWM will result in superior restoration of range of motion, pain, and function when compared with exercises and advice alone. Okay, so our methods for this experiment. We chose 67 eligible adults who were treated with casting after a distal radius fracture. So again, this fracture was not surgically repaired, not in this study at least, and we chose 67 adults ranging from 19 up to, I believe, 90 years old. That may be wrong, but it was 67 adults. An experimental group and a control group were randomly chosen, as in all studies. And so the control group, along with the experimental group, they both received 4 physiotherapy consultations, along with over 4 weeks, and performed upper limb range of motion exercises twice daily. So both the experimental and the control group performed that set of exercises, and then the experimental group, on top of that, would perform the supination and wrist extension, MWM, as well as instruction to self-administer the MWM into supination and wrist extension 6 times twice daily. So the experimental group did the 4 physiotherapy consultations, the 4 weeks of upper limb range of motion twice daily, and the experiment, and that's where the control group stopped. But the experimental group went on and did the supination and wrist extension 6 times twice daily. So physical measures and participant ratings of pain and disability, wrist-related activity limitations were assessed at the baseline, and they were assessed at week 4, and then again at week 12. And the participant-rated outcomes were also recorded at weeks 26 and 52, either by post or via a link to an online survey. And at weeks 26 and 52, those were completed by the participants only. They were not completed by the clinicians. So our results of this experiment: the experimental group had a greater supination than the control group at 4 weeks, with a mean between group difference of 12 degrees. So basically, at 4 weeks, the experimental group could supinate their forearm 12 degrees further than the control group. Next, we have the supination was still greater for the experimental group at 12 weeks. So basically, at 12 weeks, the experimental group could still supinate their forearm further than the control group, which is what we expected. The experimental group had a greater wrist extension than the control group at 4 weeks, with a mean between group difference of 14 degrees. Again, the experimental group could extend their wrist 14 degrees greater at 4 weeks, and then this benefit was still evident 12 weeks later, just like the supination was. The experimental intervention was estimated to increase the likelihood of being able to pour into supination and pour into pronation at both 4 and 12 weeks. So this was a prediction that the authors made. And the participant-rated measures showed similar outcomes between the two groups at 26 and 52 weeks, which again, for a distal radius fracture, after half a year and after a year of recovery, you're going to have similar results between basically anybody who's suffered that injury. Leading into our discussion, in the management of distal radius fractures, MWM appears to be an effective adjunct to range of motion exercises and advice, leading to better outcomes within 4 weeks of cast removal. So basically, this study is stating that if you have a distal radius fracture and you treat it with MWM as well as common exercises and the advice given by the doctors, then you'll have better outcomes after 4 weeks of cast removal. Adding MWM caused moderate to large improvements in wrist extension and flexion range at both 4 and 12 weeks, just like we saw in the results. Pain and function with upper limb tasks were improved in the experimental group at 4 weeks. However, by 12 weeks, it was no longer clear whether the effect was beneficial, which is okay in a study like this. 12 weeks after a fracture in your distal radius, it's going to be iffy whether you're still suffering from it or not. MWM increased the likelihood that participants could pour into supination or into pronation without difficulty at both the points. So MWM helped supination and pronation. Participants were more likely to report that they were improved on a global rating of change scale at 4 weeks if in the experimental group. So participants in the experimental group, they said they had their overall quality of life was better after 4 weeks than the control group. For our credibility of this article, it passed all my tests on the CRAP test, in that it was current, it was relevant, and it was accurate, had accurate information. The authors were obviously qualified, and the purpose behind the article is evident, and that is to inform that MWM can be a viable option for distal radius fractures. Although it did pass the CRAP test, it did have a few things that worried me about the overall credibility of it, such as the confidence intervals around some of the estimates span from very strong to very mild, so it remains uncertain whether some of the effects would be clinically worthwhile. That, as well as differences at the baseline, so the initial measurements taken, such as those in the experimental group, had twice the grip strength. So those people in the experimental group at the baseline had a mean twice the grip strength of 12 kilograms than the control group at 6 kilograms, which again, this study did not have all that many participants. It was only 67, so it's going to be hard to get a even mean between the two groups. A potential source of bias that might have contributed to the better outcomes in the experimental group was that both interventions were delivered by the same clinicians, which is also going to be hard to control, especially if you're taking participants from the same region or from the same clinic. To counter some of the forms of potential bias, the study used the physical outcome measures of range of motion were taken by people who did not know the group to which the patient was assigned. So the people taking the measurements of the wrist extension and the degrees of supination or pronation, they did not know whether they belonged to the experimental group or to the control group. Also, one of the strengths of this study was a small number of dropouts. So 97% completed the 52-week survey. The 52-week survey. So 65 out of 67 participants completed that end of the year survey, which is pretty phenomenal for a study this size. And that's going to end the presentation. Thank y'all for watching. In summation, basically MWM does benefit in treating and recovering from distal radius fractures as proved by this experiment. Thank you.